catch a lot of hair, and that's saying a lot because
you
I lose so much hair.
Yeah.
I'm super surprised that, oh, double click.
I did.
Okay.
Let me make sure. It says it's recording. Thank you for the reminder. I was so mad the other night when I thought I was recording for a student and lost the entire 2.5 hours because I didn't click. You have to click record and then you have to answer a question. And I didn't answer the question. Oops.
I had a really big white fluffy like mat, and like I just had it in our living room, and then we got puppies, and it was white, so they got like I was like, this is going to change.
Okay, so when we're giving injections, I made our pretty little thing to hang up, my arts and crafts for the day.
Pretty though.
Okay. Not as good as that, but it's okay. So anyway, I'm going to continue to put things up so that we have visual maps of where things are. Of these, I would say the intramuscular is the easiest physically to give because it's 90 degrees, you go straight into the hub. So physically, it's easier to give. Psychologically, it's harder because you're taking the whole needle and sticking it in them. So,
remind me which one's the one that stings really bad. Which is the medication?
The intradermal. And it's because there's so many nerves there. So when we're injecting the saline, which is what we're going to be using, we'll be using buffered saline, or not buffered saline, we'll be using bacteriostatic saline, so we can use multiple, we can use the vial multiple times. But it just seems like the intradermal and the sub-Q sting more than the IM. Okay. Intradermal for me is physically the hardest one to do. I can't get a wheal. So when you do an intradermal, you want to get a little bubble under the skin. We're going to practice that with the hot dogs on Thursday. We're trying to get, and I kind of want to go get some chicken, but that grosses me out. But this
hot dogs gross me out too. Just the feel of the
yeah.
hot dog.
I feel like if you
and it smells.
Yeah, I'm just not sure what. Well, we're definitely doing hot dogs. I'm sorry. A lot of people like to use oranges to teach to give injections, but oranges,
Too thick.
right. It's not the right feel. So that's why
if it's fuel.
it's
Too soft.
too soft. So it's kind of in between. I would say maybe a mushy apple might be okay, but I'm not going to go buy apples and intentionally bruise them.
Oh, people know.
So we're definitely doing hot dogs. I don't know about
What are
the
some other
chicken
things
breast.
that we can bring that would work that we could possibly bring? So like you don't go out spending money, but like if I wanted to try to do like something else, or we could probably try it. Like you said, mushy apples would work.
You could try mushy apples. Bananas might work for sub-Q.
I know when my sister, she went to this like doctor camp in California, and they did stitches on bananas because they said that the skin is like it's close to the thickness as like human skin.
Right.
So bananas might work.
So bananas might work for the sub-Q. So we'll do hot dogs with the ID, and I am going to get some chicken breasts. Maybe though I'll keep them covered. Maybe instead of opening them, we'll shoot through the saran wrap into the chicken.
Yeah, that'd be nice because we don't want to touch it.
God, no.
What if you just like individually wrapped them in saran wrap?
Yeah, I'll figure out some way to keep them contained and less gross. How's that? So we'll do our IMs, the practice IMs into chickens, and then I'll pick up a bunch of bananas, and we'll do our sub-Qs into the bananas. How's that sound? Sounds like the worst potluck we've ever had.
Raw chicken, hot dogs, and bananas.
Bananas. But that's what we'll do.
So hot dogs is going to be for the
Intradermal.
okay.
Because you have to get they've got that nice casing on them, and that way we can practice getting our wheels. So we should be able to bubble it up. Okay. The banana skins are too thick to get a good wheel on, but we should be able to feel once we are under the skin, once we're subcutaneous.
Is it
Yes,
okay
ma'am.
if like they're like bruised bananas?
Hmm?
If they're like like good banana bread bananas.
Oh, that might be too soft.
Okay. So I was gonna say I could just bring some from work.
Oh, I appreciate that. I'll just make Joel buy it. Wait till he sees my grocery list. He'll be like, "What are you doing?"
Don't worry about it.
Yeah. Okay.
Fresh.
Jackie asked if the depot shot is subcutaneous. No, it's not. That's deep IM, Jackie. So with our,
And you say I am because it's intro.
yes,
Okay.
I am. And subcutaneous can be abbreviated a couple of ways. We usually just abbreviate it SQ, but you might also see it written out SUBQ or SC for subcutaneous. Okay, SQ is the most common, but there are those other ways. And then intradermal is ID. Okay. So when we do the intradermal, I've put it up here, it goes into the upper layer of skin. Intra means within, so it's within the skin. We do this primarily for skin tests, allergy testing and tuberculosis. Those of you who've had your TB test, a lot of people call it a TB shot. I think even we have it written down as TB shot. It's a test. It's not a vaccine. Okay. So your TB test goes intradermally, and you should get a wheal. So you should get a bubble underneath the skin. So subcutaneous, SQ, SC, sub-Q, and I've seen this, but not as often, the subcut. That seems like a lot of extra things to write when you can just write SQ.
I want to ask about
Yes.
the TB.
Uh-huh.
I went to Mexico a few weeks ago,
Mhm.
and I went to the doctor to get make sure I had all my shots that you guys need. And they did the TB, and they decided to take blood instead.
Because the likelihood of being exposed to TB in Mexico is pretty high. So you may have built the antibodies. And the way the TB test works is we inject you with the antigen to see if you have a reaction. So if you were exposed in Mexico, then your body has already built the antibodies, so it would have reacted. So when they do the blood, they're just drawing the titer to make sure that you have the antibodies. One of the docs I worked for, well, the urologist I worked for during his residency worked in a prison, and prisons also have a high incidence of TB, or did 50 years ago. So he always came back. He'd do his TB test and always came back positive that he had the antibodies, which could mean an active infection. So they always had to do a chest x-ray on him to make sure that there were no tubercles in his lungs. But it was because he had been exposed and built the antibodies. So he was actually, I mean, having the antibodies is good if you don't have an active infection, because it means you're immune to it. So he could have TB patients cough on him all day long, and he wasn't going to get it because his body would fight it off.
Well, I was just curious because I had gotten it right before, and they did do the one on my skin and all. And she didn't really explain much to you, but
Right. It's just because of where you were, get a higher chance of it coming back positive, and they have to do the chest x-ray or a titer. Okay. So intradermal, I didn't have it put up here, but the intradermal is 0 to 15 degrees, so it's almost flat when you go in. And you only put the bevel or the opening of the needle into the skin before you give it. Okay, so these are very, very small volumes, like 0.1 ml. So very, very small. Okay. Subcutaneous, 45-degree angle, and I'll put the pictures up here in a minute. We give 1 ml or less. So we put less than or equal to 1 milliliter. And when we do subcutaneous a lot, we're going to rotate the sites. So people who have diabetes who have to give themselves insulin injections, they don't inject themselves in the same spot over and over again. They have to rotate them. If you are hospitalized and they give you Lovenox, which is to prevent blood clots, Lovenox goes in the stomach, but they rotate the site so you don't end up with bruises in one site. So you have to rotate the sites for sub-Q.
Have you seen those little paper, like there's little sticker things that like you can put in the papers for like hole punches? So my grandma does insulin, and she like, for some reason always forgets that she needs to rotate around. So she gets those little circles and puts them around, and since they're different colors, she has a little book, and then she says, this time we're inserting to the little green hole, and this time we're inserting to the little orange hole, and yellow, and like that. So like, that's how she gets it all around, and I think that's pretty interesting.
That's really a good idea.
Yeah, because
It gives you a little target.
yeah, she
And
goes,
you
and plus
remember
it has a
rotate.
little hole in the middle, so she kind of just puts it through a little hole. And like every day she kind of just does that, like she puts little stickers on it, and she'll be like, oh, today I'm gonna do here and here.
That's a really great idea. I thought of that. Okay, so subcutaneous, we're gonna rotate. There is an alternative method for subcutaneous, and I'll show you here in a minute. We're going to skip through this right now. IM is the fastest, oral is the slowest absorption, followed by injection. But with an injection, there's even a hierarchy there. IM is second fastest behind IV. Now, we don't do IV injections. We don't go straight into the vein, except to take blood out. So of the injections we give, IM is the fastest. We do this at a 90-degree angle, so straight in to the skin. It absorbs quickly and it's less irritating. So even though people freak out about getting an IM injection, it's less painful. So this is good absorption and less painful. And we can do, our volume can be higher with that. I don't remember what the book says. I think the book says up to 5 mLs, but that's a lot. I wouldn't do 5 mLs into somebody. I would split that dose. Okay. The Z-track method, we'll go over that later in the mod, but that is a type of IM injection. When we're giving IMs, we have different sites. Again, we'll go over that probably next week, okay, when we start doing it. IV is straight into a vein. Do we do that? No, we're not. Okay. So I'm going to flip through here. We have these different, just put larger volume on. We have different cartridges or different types of packaging. One of them is a cartridge like this, where it comes, the needle is already attached, the medication's in here, and then we screw this piece on. So it doesn't have the plunger. We screw it on. It's called a tubex syringe, TUBEX. When we're in the lab in the next couple of weeks, I'll make sure to get one of these out so you can see how it works. Okay. We use these tubex syringes for things like penicillin and certain narcotics, but tubexes are really kind of on their way out. Okay. We have ampules, which is this little glass thing. It's got a thin neck. I'll show that to you in lab. There is a specific way to open an ampule, and I have the scar to prove it if you open it wrong. The ampules are glass, so that's why I have a scar somewhere on my pinky finger. It's this one, because instead of snapping it away from me, I snapped the ampule towards me and dragged my pinky across the broken glass, which is dumb because now I'm bleeding and I've contaminated the ampule. So I'll teach you guys how to do it properly. We don't see glass ampules very often anymore. There's just better ways to do it. And vials. Vials can have liquid or powder in them. If it's powder, can we inject powder? No. We're going to dilute it with something called a diluent. I don't know why they call it a diluent, but it's like efficacy and effective. You know, it's a special word for a pharmacy. Okay? Because all it does is dilute it. Okay? Okay, no problem. Vials can come single or multiple dose. And usually the medication is dissolved into like an aqueous base, so we can just withdraw it and inject it. If it is oil-based medications tend to be hormones. So Depo-Provera, testosterone, estrogen injections, those are oil-based hormones. You want to use the biggest gauge needle you can tolerate for that. I would use nothing shorter than, or nothing smaller than a 21 gauge because it's so thick. So you're not doing your patients any favor by using a small gauge needle for things like that. A lot of people will say, I want you to use the smallest needle. The problem is that if you use the smallest needle, it takes more force to get the oil-based stuff through it, and you end up with actually more tissue damage than if you used a bigger needle, a bigger bore needle, and just got in and out.
Did they ever shoot back up?
Yeah, sometimes. So the type of needles that, or the type of syringes that I have here are called Luer lock syringes, where the needle screws onto the syringe. There's also a type called slip needles or slip syringes, where you just push the needle onto the syringe. The problem with slip syringes is if there's too much pressure when you're pushing down on the plunger, it pops off. So now you've got the needle in the patient and the medication spraying all over the room. So I purposely buy the Luer locks so that can't happen. I can show you guys slips when we go in on Thursday. I can show you what a slip syringe looks like. If you are ever in charge of ordering at whichever office you end up at, order the Luer locks. Because, I mean, the slips are half a cent cheaper, I think. But there's nothing worse than giving a kid their shots. Because, you know, kids, they get 4 shots at a time. Then on your first or second shot, they tense up, causes back pressure, and then now you've blown their, whatever, their DPT all over the room, and they've still got a needle in their leg. So I would encourage you all to use the Luer lock where you screw the needle on instead of push it on. Makes sense?
Well, because I don't know if they do have a lot of it.
Right.
My dad does do injections of you on our courses.
Mm-hmm.
Somehow they like make themselves so stiff that the drug is so hard to get into.
Yeah, it's tight, so it pushes back on.
Mm-hmm.
Yeah.
And I think it's the slip on the
You can give bu orally, right?
mm-hmm. But they get like, my dad prefers injecting.
Okay.
But some of our horses prefer everything injected because they want their
Right.
Because they are
horses are
racing horses,
mm-hmm.
they get called you.
Right. Yeah. They're just a little high strung, those racing horses. We should always check the expiration date, right? And then if there are, if it's something that needs to be mixed, you just roll it between your hands like this. Okay. This is a good way to warm medications as well. So penicillin has to be kept in the refrigerator. You don't want to inject it while it's cold because that's like injecting refrigerated Elmer's glue. Penicillin is super thick. So you want to warm it up and you just roll it between your hands. If you ever have to give antivenin, if somebody ever gets snake bit, you have to give antivenin. You have to mix and mix and mix by rolling it between your hands. I think it's like 5 minutes, 5 to 10 minutes. You just, when I worked in the ER, whenever anybody came in whenever we'd get a call from the ambulance saying they were bringing somebody in with a snake bite, there'd be 4 or 5 of us just standing around, rolling the anti-venom to warm it and to mix it. And that stuff's expensive. It's like $1,800 a dose. Don't get bit by a rattlesnake, I'm telling you. It's so expensive. And that was 20 some years ago. It hasn't gotten cheaper. Penicillin itself doesn't hold up to the stomach acid very well, but there are psyllins that were made for oral ingestion. But the actual penicillin is best injected. Jackie says it's been a lot more expensive than that. I'm going to ask her. Several thousands of dollars for a dose of antivenom. Yeah, it's up there. Wow. Don't get snake bit, is what I have to say about that. Ampules are 1-dose containers. They're just a little glass vial. And they've got a score around the neck, like where it's been cut partially. So when you open it, it'll open. You need to tap it to make sure all the medication's down in the bottom. But the surface tension of the liquid and combined with the glass, if you turn the ampule upside down, the liquid won't come out. You have to draw it out. And you're supposed to use a special filter needle to draw it out with. I've never worked at a place where we bought those special filter needles. We just sucked it up with a regular needle. Okay. The pre-filled cartridges look like this. So you've got your medication here. This would need to be mixed. This is penicillin. So you need to warm it and mix it till it was all one uniform color.
And you can just roll it.
And you just roll it. Mm-hmm. And then this piece right here screws into this. And that way you can inject it.
I've seen injections like the one on the top where it looks something like that, and you just click it with a little pen and it goes in.
Oh, so like a spring-loaded auto injector. Yeah. We don't use those, but yeah, they do have those spring-loaded auto injectors. In fact, there are some insulin devices that are like that now. Okay. So the syringe, we've got the barrel of the syringe, the hub. You guys remember from phlebotomy, we talked about the hub. Okay. That's really, even though in phlebotomy we're talking about the needle holder, when I say, hey, give me a hub, you know, I mean to give me a needle holder or a tube holder. The hub is actually a part of the syringe and the blood draw needle that screws together. Okay. And then we've got the needle and the safety, the needle stick prevention device. Do we trust them? No, we don't trust the safeties. In fact, the needles I ordered don't have safeties on them because do we treat them any differently? No. I kind of feel like if you have a needle without a safety on it, you tend to be less likely to be careless. Does that make sense? Mm-hmm. So when you get out in the field, if you work at a place that has safety on their needles, don't get careless. Don't do something stupid like stick it in your pocket after you engage the safety, please. Where do needles go? In the sharps container. Yep. This is the plunger. And then we've got the top of the plunger has the leading ring and the trailing ring. The only reason you need to know this is when we measure medication, we always measure at the leading ring. Okay, so if I tell you to draw that to, this is 1 1/4 cc's, then you would draw the leading ring back here. Okay. When we are giving injections, the IM, we go all the way to the hilt. The whole needle goes in. That's why I said it's psychologically harder to give an IM injection, but physically easier. When we are doing intradermal, this bevel right here where the opening is, that's the angle where the opening is. You guys remember that from phlebotomy? that just barely goes under the skin when we're doing intradermal. And then when we're doing sub-Q, we use about half of the shaft. Okay. Just like phlebotomy, bevel is always up when you give injections. Okay. Are you guys comfortable with gauges? So the bigger the number, the smaller the bore, or the smaller. It's the same as with phlebotomy, so the needles are across the board. In fact, the color coding is the same. So a 22 gauge in phlebotomy is black, and 22 gauge here for injection is black. Okay, so it's standardized color coding across all needle gauges.
I haven't took phlebotomy, so who wants to?
You'd like to take it? I don't know when, though. I don't know when I'm teaching it again. It's a fun class, though, I think. And having had this class first, it's kind of, there are benefits to having this class first. Having this class first, you'll get over your nerves of poking somebody. People who've already had phlebotomy are over that nerve. So this class is actually easier for them than, because they've already been in phlebotomy and they've already had to hit that little tiny vein. Now their targets look huge. But they had to get over that psychological hump of sticking somebody. By the time you get to phlebotomy, you'll already be over that hump, and it'll be easier for you to do your first stick. So there are benefits each way. We're going to choose the length based on the type of injection, the patient size, the amount of fatty tissue, or the injection site. That makes sense, right? We don't need a 2-inch intradermal needle if the only thing that's going to go in is the bevel. But if we are doing a deep IM injection, we might need a 2-inch needle. Those usually go 1.5 to 2 inches. Okay. And while I'm here, let me just, actually I'll just finish this up. I'm probably not going to go any further on the slide show, but I want to make sure that I finish up the diagram here. So would you go ahead, Glynis, and turn on the light? Okay, so IMs, we know it's good absorption, less pain, we can give a larger volume, and we go in at 90 degrees, right? So the gauge needles we would use for this would be, 21's pretty typical, but 21 to 23 gauge needles and 1.5 to 2 inches. So I'm going to put 21 to 23 gauge, 1.5 to 2 inches. Intradermals can be 27 to 30 gauge, and these are usually 5/8 of an inch. If we got any shorter than that, we can do half inch to 5/8 of an inch. But if we did any shorter than that, we wouldn't be able to control the angle because the barrel of the syringe is too big. So we have to have some length to control the angle of entry. And then sub-Q, typically 23 to 25 gauge. And we can do 1/2 inch to 1 inch. Could we go longer than that if we had to? Yeah, we could, without a problem. Now down here I have an alternate sub-Q angle. Okay. These are for people who, like older people or people with a lot of loose skin. It's hard to get under their skin. So what we do is we bunch it up and kind of separate the subcutaneous layer from the muscle layer, and we go in at 90 degrees. We would still use the same size, probably a 1/2 inch needle instead of a full inch needle. And the only thing that changes here for this alternate is that you're changing your degree. Instead of 45, you're pinching up the skin and going in at a 90-degree angle. So you're kind of making a pocket. Here's where you're pinching up the skin. So you're making a pocket, a subcutaneous pocket that you're injecting into. Does that make sense? We don't do this very often. We do that with hospitalized patients. We do this with Lovenox in the abdomen. A lot of the auto injectors for insulin, they go in at a 90-degree angle, but the needles are so small that they don't have to bunch it up. They're just only long enough to go into the subcutaneous space. Make sense? Okay. So for the last few minutes, I think I hit everything on the ADME quiz. Those of you who took it this morning, does that sound familiar? Okay. So what I want you guys to do is go back in and take the ADME quiz, and the new access code is ADME 2. So capital ADME 2. So if you already took it at the beginning of class before you reminded me that I put stuff in there we hadn't gone over, the highest grade will count.
So even if I'm taking it the first time, I still put the 2?
Yes. I need to get a mandate to the level. So increasing use. And then when you guys are done with the ADME quiz, you guys can go.